Hello everyone. I'm back today. I received compliments about my previous videos. I thought I'll do some videos which are most practically oriented and which can be inculcated in our day-to-day practice. As you all know, labor forms the bread and butter in our lives as Ojibweans. We have to know what is important in the monitoring of labor. As you see here in my first slide, modified WHO partograph and WHO care guide are very important to monitor the woman during the progress of labor to ensure safety to both the mother and the baby. Why delay? Let's move on and understand more about these two. My today's agenda is to cover the importance of both modified WHO partograph, its components and its practice, and why presently the WHO labor care guide has come into picture and what is its importance when compared to the modified partograph. And we also have to understand the clinical application of these two and my take home message. Going back to history, we had Friedman's cervicograph, which was used to assess the monitoring of labor based on the cervical dilatation. Then following that, the World Health Organization came up with an initiative to monitor the progress of labor by using a traditional partograph. This traditional partograph had the latent phase of labor, that is latent phase of first stage of labor was included in it. But as we all know that this latent phase might vary from woman to woman and it might not form the criteria for intervention. So if we use this as a method for progress of labor, we might take unnecessary decisions as taking her up for a cesarean section or unnecessary augmentation of labor. So WHO came up with a new amendment in 2000 called the modified WHO partograph, where the latent phase of first stage of labor was removed. This is the modified WHO partograph. Even today it is in practice. What are different components of modified WHO partograph? The first section includes the name of the woman, gravida, para, her hospital number, the date of admission, the time of admission to the labor room, and ruptured membrane since how many hours. This forms a very important information for documentation and for monitoring. The second important column shows the fetal heart rate. This fetal heart rate is normal between 110 to 160, and we all know that it should be monitored every 15 minutes in the first stage of labor, that is the active phase of first stage of labor, and every 5 minutes in the second stage of labor. When do we have to start this WHO partograph? This partograph, which is modified, which has to be started at the onset of active phase of first stage of labor. What is active phase of first stage of labor? It is more than 4 centimeter cervical dilatation. If the woman is 4 centimeter dilated, then we have to start plotting the partograph. What if the woman comes in 7 centimeter? You can still plot the partograph, but we have to plot at the onset of alert line. I can show you in this picture. If she's coming at 7 centimeter dilatation, our first reading should be on the alert line. On the alert line at 7 centimeter, we have to plot the partograph, and the partograph will start from here. This is the place where the partograph is starting. The fetal heart rate also should start from the same point, and the next assessments also should go from this point. We need not start from here because our first marking is on the alert line. The first very important rule for plotting a partograph is the first marking should be on the alert line. The FHR, as we all know, it should be between 110 to 160, which was also discussed in our previous video. Anything going beyond the baseline or beyond 20 beats per minute, above or below, we must see what is happening. So between 110 to 160 is normal, but if it is going less than 110, we call it as fetal bradycardia, and more than 160 as fetal bradycardia, and we have to see what might be the necessary cause. The next important column which we see is the amniotic fluid. So we have to see if the membranes are intact or ruptured. If they are intact, we have to write it as I. If they are ruptured, we have to see what is the color of the amniotic fluid. So if it is blood stain, mark it as B. If it is meconium stain, mark it as M. Or if there is no amniotic fluid, like if there is absent liquor, we can mark it as A. The second important thing is molding. So what do we mean by molding? It is the overlapping of the skull bones. So if they do not overlap, it is called as grade 0. If they just touch each other, it is called as grade 1. If they overlap each other but still reducible after contraction, it is called as grade 2. If they are overlapping with each other and they are irreducible, it is called as grade 3. So grade 3 mold is definitely not normal, and we have to intervene and see if there are any causes of cephalopelvic disproportion or obstructed labor. The very important part of the WHO modified partograph is the cervical assessment. So this cervical assessment is important for us to see the monitoring of labor. So as we all see, the cervix in centimeter is plotted on the vertical axis, that is the y axis, and the hours or time is plotted in the horizontal axis. So as I already mentioned, the first marking should be over the alert line. So if the mother comes at 4 centimeter of dilatation, or if she is progressed to 4 centimeter of dilatation, that is the active phase of labor, we will start marking. So we will do a vaginal examination and we will see this 4 centimeter. Our first marking is on the alert line. And how many times, or what is the interval in between pervaginal examination? So every 4 hours we have to do a pervaginal examination to assess the dilatation. So then we will go on marking the partogram. And to see the descent of the head, usually we adopt the Crichton's rule of 5. So what is Crichton's rule of 5? We have to place our ulnar border of our right hand over the pubic symphysis and grasp the presenting part. So if all the 5 fingers are used to grasp the presenting part and move, then it is called as 5/5 palpable. If only 4 fingers are used, then it is called as 4/5 palpable. If only 3 fingers are used, then it is called as 3/5 palpable. If only 2 fingers are used, then it is called as 2/5 palpable. If only 1 finger is used, it is 1/5 palpable. If we are not able to palpate the fetal pole, then it is called as 0/5 palpable. So this is called as Crichton's rule of 5. So we can assess the descent by using the abdominal method. So this negates the use for pervaginal examination to assess the descent and increase in pervaginal examination, which might lead to infection. So fourth hourly pervaginal examination is indicated. So if it is less than 1/5 or 0/5 palpable, then it is said to be that the head is engaged. So there is something called as an alert line and there is something called as an action line. So if the progress of labor is crossing the alert line, then the clinician should get alerted. So what might be the cause for the delay in the progress of labor? So it could be either the 3 P's. So what are the 3 P's? It could be either the power or the passenger or the passage. So power is the uterine contractions. Passage is the birth canal or the pelvic adequacy. And the last one is the passenger, that is the baby. So any of these could lead to the delay in the progress of labor. So once the alert line is crossed, we have to see why there is a delay and we have to do some necessary steps. So if the contractions are less, we can augment the labor. And we have to see whether the head is descending. Is there any presence of caput? Is there any presence of molding? So we have to assess. And but if the line, that is the action line, is crossed, definitely we have to intervene, because if the action line is crossed, that means vaginal delivery is unlikely, or we have to intervene and expedite the delivery by doing either an operative delivery if she's in second stage of labor, or a cesarean section if she's still in first stage of labor. So this is the assessment and plotting of the progress of labor based on cervical assessment and descent of head. So that is called as Crick's rule of 5. So coming to the next column, we have to always plot the contractions per 10 minutes. So as I told you, power is very important for the progress of labor. So how do we mark? So I have shown in this picture, if there is less than 20 seconds, we have to put dots. If it is between 20 to 40 seconds, we have to put cross slanting lines. More than 40 seconds, we have to dark it. So if each contraction is lasting for less than 20 seconds, or 20 to 40 seconds, or more than 40 seconds, and how many contractions? 10 minutes. So this is, we are plotting in the contractions column. And if it's an augmented labor, we have to mention the number of units of oxytocin which is used and what is the drop rate or the titration. So this should be mentioned in the next column. And any IV fluids or analgesic drugs or any other drugs which are given during the labor, the dosage, the course and the route must be mentioned in the next column. So this finishes the fetal monitoring and the progress of labor. Next important the column is the maternal monitoring. So we have to see the pulse rate and blood pressure at the admission and repeat fourth hourly. And if she's a case of hypertensive disorders, then we have to repeat every hourly. So then pulse is indicated by a dot and BP is indicated between a straight arrow. So if the pulse is around 60 beats per minute, then we will plot it as 60 here. So I hope I am visible. So this is 60. Then if the BP is 120/80, then we mark it as 120/80. Like this. So then the temperature at the admission to the labor room should be mentioned, and it's very important in case of maternal hyperpyrexia or when there is any suspicion of chorioamnionitis. And the urine examination should also be done at the time of admission, that is protein, acetone and volume of urine, and it should be repeated at least fourth hourly or daily once. So this is about the modified WHO partograph. Hope you all understood. So, then WHO decided that it is not only important to ensure the progress of labor, the maternal and fetal care, but also some of the important principles which have to be acquired or practiced during the labor process. So what did WHO do? It released some new recommendations in the year 2018, and also it released something called as WHO Labor Care Guide in the year 2020, and a special term called as the respectful maternity care was brought into picture. So what is this respectful maternity care? So this is important. So carefully listen. So it refers to the care organized for and provided to all women in the manner that maintains their dignity, privacy, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childbirth. So, this is the complete definition of respectful maternity care. And WHO also released certain recommendations which are depicted in this picture. So, respectful labor and childbirth, emotional support from the companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation, audit and feedback, oral fluid and food intake, mobility in the labor and birth position of choice, pre-established referral plan, continuity of care. So all these form the essential elements of the WHO recommendations. So we have to understand what are the do's and what are the don'ts according to this new WHO recommendations. So what are the do's? The care should be given throughout labor and birth. It is not only during second stage or during the birth of the baby. Throughout the labor, from when the mother is in active phase of labor, we have to ensure that she has a birth companion of her choice, and effective communication should be there with the mother, and we have to give her some pain relief which she desires to, and we have to give her some freedom to adapt to the position, and we have to tell what she can take and what she cannot take with respect to oral intake. So all this forms the care throughout labor and birth. And also, WHO has defined some recommendations during each stage of labor. So, what does WHO mean by active phase of first stage of labor? So, it means that the cervix is dilated more than 5 centimeter of dilatation. So, this is a very important difference between the partograph and the labor care guide. So, there it was 4 centimeter dilatation, but here it is 5 centimeter dilatation. And it also mentions the things which we have to do in the first stage of labor and which are not indicated in the first stage of labor. So they tell that the labor care guide should be monitored, and we have to do intermittent auscultation. So 1-to-1 intermittent auscultation every 30 minutes during first stage of labor, and sorry, every 15 minutes during first stage of labor, and every 5 minutes during the second stage of labor is recommended according to NICE guidelines, and it is also implemented by WHO. So this intermittent auscultation is important, and we have to ensure the mother is taking proper oral intake, adapting to the position, and it also tells some don'ts. So what are the don'ts? It does not advise clinical pelvimetry at admission. So we do not need to do a clinical assessment of pelvis at the time of admission, and there is no need of intervention in the late phase of first stage of labor. There is no need of labor admission test, that is the CTG, at the time of admission, because it does not have any paramount importance. So we just can auscultate the FHR by Doppler, and that is more than sufficient for a low risk pregnancy. Unlikely in a high risk pregnancy, it is better to do the CTG. And they also tell that parts preparation by pubic shaving is not recommended, and enema in all cases is not recommended. Electronic fetal monitoring and continuous monitoring through CTG is not recommended, and augmentation of labor is not recommended in all cases. We can wait for spontaneous progress of labor, and vaginal cleansing with chlorhexidine and other antiseptics are not recommended, and routine use of oxytocin in epidural analgesia or elsewhere is not recommended. Only if the power is less, that is the uterine contractions are less, then we can augment labor, and there is no need of routine use of antispasmodics for progress of labor. There is no need of IV fluids whenever there is any suspicious FHR. So these are the very important first trimester recommendations. What are the trimester stage recommendations? So these stage recommendations is the mother can adapt to whatever position she wants, and she can push according to her expulsive power. So we cannot tell that you have to push like this or don't push like this. We have to allow her, and we have to allow her to take the decision on how she wants to push during second stage. And episiotomy is not indicated routinely. Fundal pressure and uterine massage also are not indicated routinely. So in third stage, only two things are recommended. One is routine use of uterotonic, that is 10 international units of oxytocin should be given to the maternal buttock intramuscularly after the delivery of the baby within 1 minute. So this is called as active management of third stage of labor by giving a uterotonic. The second thing is delayed cord clamping. We have to delay the cord clamp at least for 1 minute if there is no need of urgent neonatal resuscitation. So at least 1 minute we have to wait both in vaginal and cesarean sections, and that is called as a delayed cord clamping. And delivery of the placenta should be taken by controlled cord traction by modified Brand Andrews method. So there should be a traction and there should be a counter traction to prevent inversion of uterus. So these are the third stage recommendations. So according to recent guidelines, uterine massage is not indicated. And what are the routine care for the newborn? So immediately after the newborn is delivered, we have to provide skin to skin contact, and the breastfeeding must be initiated as soon as possible. And routine vitamin K administration to the newborn, that is 1 mg intramuscular, should be given at least after the breastfeeding has been established, that is within 1 hour. But what is not recommended, routine suction of the oral or nasal cavity is not recommended unless there is any fetal distress, unless there is any need for intervention. And the last care is the care for the mother after birth. So immediately after birth, we have to check her pulse, blood pressure, the tone of the uterus, any active vaginal bleeding, and we have to see whether she is comfortable. And at least after 6 hours, we have to repeat her blood pressure assessment, and we have to see whether there is any ongoing bleeding or heavy bleeding, or the uterus is contracted or not. And we have to see within 6 hours whether she has void urine or not. So this is the care which has to be given to the mother after birth. And the last one is WHO does not recommend routine use of prophylactic antibiotics for a low risk pregnancy in a vaginal delivery. Even though if episiotomy is given, there is no need for routine antibiotics, and the mother can be discharged in a low risk pregnancy within 24 hours. So these are the common or most important recommendations which the WHO initiated in 2018. So what about labor care guide? So this is an important picture which has different sections of the labor care guide. So there are 1 to 7 sections. The first section is mainly the patient information, and we will deal about each section in detail. So what is the first section? So before going into the sections, we must know the principal aims of a labor care guide. So why this has come into picture is very important. So what are the principles? So first, it's to guide the monitoring and documentation of the well-being of the woman and baby and the progress of labor. The second is skilled birth attendant to offer support during labor throughout the labor to ensure positive childbirth experience for the woman, and also assisted stillbirth personnel to promptly identify and address emerging labor complications, and based on the labor observations, and we have that are intended to trigger reflection and specific actions to be taken if any abnormal findings are detected. And the fourth important point is we have to prevent unnecessary use of interventions, unnecessary using of forceps, unnecessary doing a cesarean, unnecessary using oxytocin. So all these are not recommended. And the last important thing is we have to support the audit and quality improvement of labor management. So if something goes wrong, we have to go back and do an audit to see why this has occurred. So these form the main principles of the labor care guide. Now we have to answer these three important questions. So for whom it is indicated? For all women, we can plot a labor care guide. For low risk or high risk women, we can plot it. When? After the active phase of labor, that if the woman goes to 5 centimeter of dilatation, that is means that she's entered the active phase of first stage of labor. That is when we start plotting the labor care guide. Where can be used? It can be used in all health facilities irrespective of which level. It can be used in primary or secondary or tertiary. So wherever we are monitoring the progress of labor, this labor care guide comes into picture. So how do we monitor the labor? So this is by a systematic and consistent application. That is, first we have to assess whether it is the well-being of the mother or the baby or the progress of labor. Then we have to record the same thing, that is document these observations. Then we have to check the threshold, whether it is in the alert column. Then we have to plan the intervention if needed. So this is very important and we have to take the consultation from the senior consultant. So usually in UK, there are midwives. So if there is any problem, they shift the mother from the midwifery unit to the consultant-led unit. So this can be practiced where if you are in doubt, you can take an opinion of a senior consultant. So what is the section 1? It is almost same like the partograph, includes the name, parity, whether the labor onset was spontaneous or induced, active labor diagnosis from when she is in active labor, that is the date and time, and the ruptured membranes, date and time, and any other risk factors. So the very important addition to this labor care guide is risk factor assessment. So any maternal risk factors or fetal risk factors or placental factors we have to be addressing should be mentioned here. So that gives us the importance to monitor the woman throughout. So this section is mainly identifying the information and labor characteristics at the time of admission. The second important section is support care. So who is the birth attendant who is there? So in all other sections, there is the horizontal column, that is the time column with hours. So if it is 6 o'clock, it is 1 hour. 7 o'clock, it is 2 hours. And there is something called the active first stage of labor and the second stage of labor. So what are the components of supportive care? 4 components. One is the companion. So whichever companion the mother wants next to her during this process of labor, she can allow them to stay with her. So either her husband or her mother or her sister. So whoever she wants and she is comfortable, they can stay. So N stands for no, Y stands for yes, and D stands for the patient has declined. And then we have to give her pain relief. If she desires to take epidural analgesia, we have to support her decision, or if she wants opioid analgesia, we have to support her decision. If she wants birthing ball or water bath, whatever it is, we have to support her decision. And N again stands for no, Y stands for yes. And oral fluids are indicated and can be given. And then posture, we can either write it as SP, that is supine position, or MO, that is the patient is moving or she is mobile. So these form the support care. The next section is a very important thing, that is the care of the baby. So what are the important characteristics? Baseline heart rate. So we have to monitor every 1 hour what is the heart rate of the baby, whether it is between 110 to 160, and whether there is any noted of fetal decelerations, which I've already explained. So what types of decelerations? Early, variable, and late deceleration. So this can be monitored like E, V, L, N. That's no decelerations. Then amniotic fluid, if the membranes are in, we write it as I. If it is clear, C. Blood stain, B. Meconium, M. And if it is absent, A. Then we have to see the fetal position. If the fetal position is occipito anterior, we write it as A. Occipito posterior, we write it as P. Occipito transverse, we write it as T. Then we have to see any presence of cap. What is the grading of cap and what is molding? So that we have already discussed. The fourth section is the care of the woman. So as it is the same as partograph. Pulse, BP, that is systolic BP, diastolic BP, temperature and urine analysis. So systolic BP should be less than between 80 to 140. Diastolic BP should be less than 90 and the temperature should be less than 37.5, that is 37.5, and urine, if protein or acetones are present, we have to write whether it is nil, traces, 1 plus, 2 plus or 3 plus. Next, section 5. So we have to assess the labor progress. So this you have to see and it is important. So here there is contractions. So how many contractions and what is the duration of one contractions? So in 10 minutes, how many contractions she is getting? 2 to 5 is normal. So less number of contraction, more than 5 goes in favor of taking systole. And duration of each contraction. So one contraction lasting for how many seconds? So if it is lasting for more than 2 minutes, it is called as hypertonus. So this we have to write. And then the labor progress, we have to see the cervical dilatation. So we can see here it starts from 5 and 5, 6, 7, 8, 9, 10. So in each centimeter, how many hours the mother is in? So 5 centimeters, she was there for almost 6 hours. Then for 6 centimeter, she was there for 2 hours. So if in 5 centimeter, if it crosses 6 hours, it is the alert thing. And in 6, if she crosses 5, then we have to get alerted. In 7, if it crosses 3 hours, we have to get alerted. In 8, if it crosses 2.5 hours, we have to get alerted. In 9, if it crosses 2 hours, we have to get alerted. So these are the alert parameters. And the descent also we have to see. That is by Richter's rule. Next, what are the section 6 and section 7? So section 6 is medication section. So this is almost same as partograph. The oxytocin, the drip rate, the medications given, the route and dose, and IV fluids if given. And shared decision making is the final section, which is very important. So we have to assess whether she requires any thing, that is if she requires any pain relief, is there normal progress of labor, is there abnormal progress of labor, all this we have to assess and we have to plan the management. So this is based on assessment and plan. So record the overall assessment and any additional findings which are not previously documented, important for labor monitoring. So all this has to be recorded and we have plan based on whether to continue the routine monitoring or any diagnostic test, whether we have to augment the labor or do something called as ARM to augment the labor, surgical augmentation, or whether we have to use an forceps or vacuum as a part of operative delivery, or we have to take her up for an emergency cesarean section. So all these form the recording of plan, and we have to take into the consideration that the woman should be involved in decision making. This is very important. So even if cesarean section is indicated and she is not giving the consent, we have to take her points also in the decision making. If she wants to wait for another 15-20 minutes, we have to give her decision also a prime importance. And each time a clinical assessment of a baby and mother's well-being is completed, this plan should be shared to the mother for the shared decision making. So is very important. That is the labor care guide, which has to be inculcated in our routine practice. So this helps in assessment of the mother during the process of labor, also in evaluating her progress of labor, her maternal condition, and what is the fetal heart rate, whether everything is good or whether it is going according to the plan or not. So this helps us to have a combined or shared decision making with the mother. So what are the differences between a partograph and a labor care guide? In partograph, 4 centimeter was taken as the active phase of first stage of labor, whereas in labor care guide we are taking as 5 centimeter of dilatation. And the second important thing is we have included the risk factors in labor care guide. And in labor care guide, apart from the progress of labor and maternal and fetal monitoring, the other important things like ensuring the privacy of the patient, ensuring the confidentiality, taking her opinion into decision making, and allowing a birth companion, effective communication between the staff and the mother, and all this have a prime importance. So we have to create this safe birthing experience or a positive childbirth experience, which was the main motto for bringing this labor guide into existence. So this is very important because the mother has this experience of her childbirth throughout her life. So if you give her a traumatic experience, she will never forget. So it is the responsibility of each obstetrician to provide her a safe and positive childbirth experience. So with this, I conclude today's session. Happy learning. Goodbye, one and all. Thank you.